Hello, everyone. I'm Pablo Martinez from Ecuador. I participate in this amazing rotation in August. We have had the opportunity during this rotation to see many interesting cases, but we saw an excessive amount of patients and excessive prevalence of polyneuropathy, who is the topic for today. Okay. Few people probably know who these people are, and I recently discovered that. They are three physicians, two French neurologists, Jean-Martin Charcot, Pierre-Marie, and Henry Tooth. Okay, they first described the Charcot-Marie-Tooth disease. Initially, I selected Charcot-Marie-Tooth disease to this presentation, but I realized that it's most important to see how to approach a patient with polyneuropathy than see only one of this type of disease, okay? That I mentioned before is really common. We also see at least one or two patients with polyneuropathy daily in the office, and some of us are even working on a case report about this topic. Okay. First, I want to share with you the definition. We have probably heard these terms before: polyneuropathy, peripheral neuropathy, and neuropathy. Okay, but however, many times we use them interchangeably, and this should not be. Now I will explain you how to define each one. Okay. Polyneuropathy is a specific term that refers to a generalized relative homogeneous process affecting many peripheral nerves, with the distal nerves usually affected most prominently. Okay, polyneuropathy is a specific term. In the other hand, peripheral neuropathy is a less precise term that is frequently used synonymously with polyneuropathy, but can also refer to any other disorders of peripheral nervous system, including radiculopathies and mononeuropathies. For this reason, we can use polyneuropathy and peripheral neuropathy in the same way. Okay, and the last term, neuropathy, which again is frequently used like synonymously, with peripheral neuropathy or polyneuropathy, can refer even more generally to disorders of central and peripheral nervous system. Okay, the last one is a term that can cause confusion. Mononeuropathy multiplex refers to simultaneous or sequential involvement of non-contiguous nerve trunks. Okay, for example, this term can refer to a multiple compression mononeuropathies. For a pathophysiological perspective, there are two primary types of neuropathies, depending on the mechanism of damage. Okay, this is a neuron composed by its axon and myelin, Schwann cells, and another parts of the neuron. There are two types. The axonal, for example, in the cases of diabetes, of chemotherapy, and the demyelinating type, who is common in Guillain-Barré and other types like CIDP, is really common. In the axonal neuropathies, predominantly affect the axon and does not affect the myelin. Okay, for example, in Guillain-Barré, this has a significant clinical repercussions, as we can see in this table. Sorry, in this table, the axonal neuropathy follows a chronic evolution. It's most affected the distal parts of the extremities and follow up symmetric distribution in a stocking and glove pattern. The sensitive modality most common affected is the pain and temperature, and this kind of pattern has a slow recovery. In the other hand, the demyelinating type of neuropathy follows an acute or subacute evolution. It's diffuse in proximal and distal part of the extremities, and the most affected modality of sensitive is vibration and proprioception. The recovery is more rapid. And what about the nerve conduction study? The axonal neuropathy is characterized by decrease the number of nerves, the number of axons, and with that reduces the amplitude of action potential, but the velocity could be normal because the myelin is intact. In other hand, the demyelinating pattern, we have a slow lead conduction, but the average of the amplitude of action potential nerve could be normal. It's really important when we analyze these kind of results. The polyneuropathy has a wide variety of systemic causes, ranging from the most common, such as diabetes mellitus, alcohol, HIV infection, to the rare, such as some unusual forms of Charcot-Marie-Tooth disease. In this table, we can see the most common cause of polyneuropathy, diabetes mellitus. In the office, we could see at least 1 or 2 cases of this etiology every day. It is frequent. And in this table, we see how each etiology has different pattern of neuropathy. For example, in diabetes, the most affection is axonal, okay? And for this reason, it's more a chronic problem. Yeah, there are other many causes for polyneuropathy like carcinomas, lymphomas, any type of cancer, chronic kidney disease, chronic liver disease, some vitamin deficiency, and each one has different pattern of demyelinization or axonal. And with that, the clinical manifestation that we could evaluate in this kind of patients. Now we can classify correctly the neuropathy of diabetes. It's really important because when we write the notes or typing in the charts of the patient, we can use polyneuropathy or peripheral neuropathy or only neuropathy, and it is not correct. Yeah. For now, we can describe the polyneuropathy of diabetes like peripheral polyneuropathy with predominant axonal degeneration, who is chronic with distal distribution, and the pain and temperature is most common affected. Aside from chemotherapeutic drugs, a variety of commonly used medications have been implicated in toxic neuropathies. I was struck by the drugs that underlined. For example, drugs as common as metronidazole, nitrofurantoin, amiodarone, pyridoxine. These kind of drugs are really common used, and the list is so long. And we must be careful when evaluating a patient and ask about all of the drugs that they use and thus they have consumed in the past. Many times we have patients with history of cancer and we forget to ask what treatment they received. Okay, it's really important during the evaluation of a patient. This is interesting algorithm. In addition to the history of neuropathy itself, the patient should be asked about recent viral illnesses, HIV infection, systemic symptoms, new medication, toxins, alcohol, family history. After an adequate clinical history, all of those neuropathies with hyperreflexia or increased tone will be classified as central process or an upper motor neuron pattern. In the other hand, if the process has symptoms like hyperreflexia, sensory loss, atrophy weakness, it could be classified like a lower motor neuron, and it can be classified based on the EMG. The use of AMG or nerve conduction studies as the initial diagnosis procedures for patients with suspected polyneuropathy when there is no clear etiology. Okay, when symptoms are, for example, severe or rapidly progressive, and when atypical feature, including, for example, asymmetry, motor predominance, acute onset, prominent autonomic involvement, and others, we use the EMG and nerve conduction study. If we have an EMG that shows predominant affection of nerve root or a specific nerve, we must do the workup with the appropriate images to this specific zone. For example, MRI of the lumbar spine or MRI in the hand and another specific places. And in the case of mononeuritis multiplex, a good option is to request a serologic study for viral infection, for example, hepatitis, and less frequently a biopsy in this way, okay? When we have a normal EMG, we must keep the patient under observation, and it is recommended to repeat the EMG in the following 6 months, okay? In the case of finding an axonal pattern in the EMG, we must do an investigation of all of these possibilities, okay, and request this test: B12, TCH, glucose, ANA, erythrosedimentation rate, and proteins in serum, okay? In the case that we have EMG with demyelinating pattern, we must differentiate between those with patients with a family history or those without. If there is a family history, we must rule out a Charcot-Marie-Tooth. Okay, this is with genetic testings and genetic counseling for the family. And in the case, is there no family history, we must request all of these tests: proteins in serum, in urine, serologic tests for hepatitis B and C, HIV, and some antibodies were less common. One of the most common important etiology of polyneuropathy with lower motor neuron signs and the myelinating pattern in the EMG is the CIDP, who is really common seen in this kind of consult. And if we have a mixed pattern, we can evaluate all of the tests in between categories. The hereditary peripheral neuropathies have been classified based upon clinical characteristic, mode of inheritance, electrophysiological features, metabolic, genes, etc. The primary hereditary neuropathies predominantly affect the peripheral nerves, okay? In this table, we can see many etiologies, but I will show you the three most common hereditary neuropathies, polyneuropathies: Charcot-Marie-Tooth type 1, type 2, type 1, but X-linked, okay? We can see here that only the type 1 has an axonal pattern of neuropathy, and for this reason, we can review again. In this kind of degeneration, the nerve conduction velocity is completely normal or mildly reduced. The myelin sheath is still normal until the last periods of the disease, okay? Okay, we can start talking a little more about CMT. The CMT is divided into specific types labeled as CMT type 1 through 4, as well as an X-linked category based on a combination of the clinical features and the mode of inheritance. Within each category, and a specific subtype associated with a particular gene is assigned with a letter. For this reason, in the literature, when we review this topic, we can see CMT1A, CMT1B. The letter represent a specific gene that was detected, okay? The CMT may be inherited in autosomal dominant inheritance, X-linked, or recessive, okay? The most common type of Charcot-Marie-Tooth disease is the type 1, okay? Represent almost 50% of the patients, and the most common within this category is the type 1A, okay? The second most common is CMT2 with 15 to 30% of the patients, and less common the other types, okay? What about the clinical manifestation? The most initial presentation of CMT is distal weakness and atrophy, manifesting with foot drop, pescabus. The sensory symptoms are often presented, but tend to be less prominent in the most common CMT subtypes. The later in the course, the foot deformities such as hammer toes and weakness, muscle atrophy, and for sure problems with the gait and the walking in this patient. There are dozens of related genes, but I want to show you the four most frequent and which CMT subtype they belong. The here is the four most common genes. The first one, PMP22, related with CMT1A, which is the most common type. The second one, MPZ, related with CMT1B. GJB1, related with CMT1, but X-linked. We have a patient with this kind of this type of Charcot-Marie-Tooth now in the consult. And the last one, MFN2, who is related with CMT2A, is the most common type of the subtype 2 of Charcot-Marie-Tooth disease. These kind of genes codified to proteins that contribute to the structure and normal function of the peripheral nerve myelin. One of the most characteristic findings in CMT is this. Was usually the sural nerve biopsy on patients with this kind of disease. And the onion bulbs, like in this slide, are characteristic feature. They reflect the repeat demyelinating and remyelinating and represent the redundant Schwann cells, collagen, and fibroblasts. Another common findings in this kind of biopsy is the secondary axonal change, but it's less frequent. What about the treatment for a patient with CMT? The management of CMT is currently supportive. Sadly, there is no curative treatment for CMT. The management of CMT includes occupational therapy, physical therapy, some painkillers, muscle to the drugs for the spasms and cramps in muscles, but there aren't any kind of definitive treatments. This is the most new study that I found in PubMed, who talk about the use of small nucleotides targeting mRNA or microRNA and the genetic therapy to stimulate or abolish the expression of the genes. This is the future for us, and thank you so much. This is my presentation. If you have any question, please let me know. And it's amazing to see all of the doctors over the world. Thank you so much.
Okay.